So good evening, everyone. The topic of today's discussion would be my topic is would be clinical presentation and diagnosis of functional dyspepsia. So my aim would be to define what is functional dyspepsia according to the Rome 4 criteria, or how do we label functional dyspepsia, and how many tests are required before we label the patient as functional dyspepsia. So that we can plan the treatment accordingly. Dyspepsia actually is a general term which means any problem relating to the upper abdomen like discomfort, pain, burning sensation, or early satiety feeling of fullness after meals, inability to complete the normal meal. So it is the whole this gamut of terms are labeled as dyspepsia. So before investigations, when a patient has these symptoms, we call these as uninvestigated dyspepsia because it has not been investigated properly, and so we can label this first. And then if we see that after evaluation, which includes some basic blood test and upper GI endoscopy, which may not be required in all cases, but when we do upper GI endoscopy, that is the only thing by which we can confirmately rule organic causes like peptic ulcer disease, some carcinoma going on, or H. pylori infection, or some erosions or ulcers, or gastric outlet obstruction. So all these things which can cause dyspeptic symptoms, when they are ruled out on upper GI endoscopy, then we label the patient as functional dyspepsia. And up to 70% patients presenting to OPD in various studies have functional dyspepsia, which basically means that they do not have any organic pathology, while 30%, up to 30% patients may have organic pathology ranging from all those which I mentioned. Besides this, other causes of dyspepsia are basically ruled out on a proper history taking and on some basic lab tests like CKD patient might have dyspepsia due to uremia. A cardiac patient might have dyspepsia due to a heart failure causing back pressure and edema. And likewise, any uncontrolled systemic comorbidity can have dyspepsia, and also all diseases also come under organic dyspepsia. So practically, when we rule out all any systemic disorder and any local disorder by endoscopy, then we label as functional dyspepsia. So why is it important? Because the treatment plan changed entirely. If the patient does not have any organic pathology, and so treatment is different. While if we find some organic pathology, we treat the specific thing, and the patient can be get rid of that dyspepsia. So globally, the prevalence rates in population range from 20 to 30%. While the precise prevalence in India is not available, various studies, small studies have been done. The estimates vary from 7 to up to 50% in Indian population, and up to 20 or 40% patients have functional symptom in Indian clinical settings. But again, the very good long data is not available. So what is the pathophysiology of this functional dyspepsia when we label that is there is no organic disease? So the pathophysiology is as with common disorders of gut-brain interaction. There are multiple physiological factors which have been linked, which can cause dyspeptic symptoms, starting from the CNS modulation. The effects of CNS are the major effects because as we all know that in the Rome 4, these disorders were renamed as functional GI disorders, as disorders of gut-brain interaction. So initially termed functional GI disorders, they changed to disorders of gut-brain interaction because the major component in this disorders is thought to be from the brain. So anxiety and stress modulate this presentation. Then visceral hypersensitivity, again a part of the increased CNS and systemic effects. Then the other things labeled as GERD, yes, but it is not. It doesn't come into functional dyspepsia. But acid reflux with no basically damage is called reflux hypersensitivity. That is not a part of today's talk. We will not go on GERD at all. Then gastric inflammation by bacteria H. pylori is very common in a population. And the policy, as will be discussed by Dr. Srihari, when we have a dyspeptic patient, it's always better to test and treat H. pylori infection. So by treating H. pylori alone, if the dyspepsia goes within 2 weeks or 10 to 14 days of therapy, then that is a H. pylori associated dyspepsia. That is not a true functional dyspepsia, and then we can stop the treatment altogether. But if the symptoms persist even after eradicating H. pylori, that indicates that the dyspepsia, H. pylori was not the cause of dyspepsia. So that an endoscopy is normal, obviously. I'm talking. Then that patient is labeled as functional dyspepsia. So we should test and treat this for this organism. Then duodenum is a new concept. That duodenum is now called the basic, maybe the seat of origin of functional dyspeptic symptoms. In which we don't actually take these infections as functional dyspepsia, but in dyspepsia patient, duodenal inflammation in the form of eosinophil mast cells have found to be increased in patients in subset of patients of functional dyspepsia. So this is all in the pathophysiology. But on the right side, the what happens in the motility changes which happen in the stomach are decreased fundic accommodation. That is, when we take meal, I think I have a diagram for this in the subsequent slides. Okay, I'll move that later. So when we take meal, the fundus relaxes. It gives space for the food to stay there. But in some patients, this is defective. This mechanism is defective. So this fundus cannot accommodate, and this will lead to postprandial type of dyspepsia, the PDS symptom, which we call. Then abnormal distribution of gastric contents, delayed gastric emptying, abnormal movement that happens in diabetic patients. So again, that is not a true functional dyspepsia. Then over-destination of antrum and intestinal dysmotility all may be linked to dyspeptic symptoms. So what are the dietary and lifestyle factors in these patients? So obviously these patients do have some factors which need control, and it basically comes in management part, but I'll be discussing what can cause visceral hypersensitivity. So patients, especially who have meal-related dyspeptic symptoms, like after meal only they have symptom. In those, the things are related more to gastric distension, duodenal lipid metabolism, more of acid and luminal gas. They may be causing symptom. Gastric dysmotility, I've already talked in the last slide. Accommodation defect, enteral distension, and disturbed intragastric distribution of contents. And then the cognitive factors, anticipation, and CNS related factors do play a role. So, how to cater with these factors are lifestyle factors, specific foods avoidance, and meal related factors have to be taken. I hope Dr. Srihari will be talking on these aspects. So symptoms of functional dyspepsia pure, it has a wide variety of symptoms, while the ROM4 takes into account the pain, discomfort, postprandial fullness, and early satiety. So these are the major four symptoms with which we classify functional dyspepsia into subtypes. I'll be doing that in the next slide. But usually the other symptoms which the patients have are bloating, belching, nausea, vomiting, and even persistent symptoms may lead to weight loss. So weight loss otherwise, which is an alarm symptom, but few patients do have weight loss, which normally is not significant enough, because if it is significant, it indicates some organic pathology. So how the Rome criteria divide them, these patients into, if the patients have bothersome postprandial fullness or bothersome early satiety, these are labeled as postprandial distress syndrome, because this happens after taking meal, and this should be present at least thrice a week to label the patient as postprandial distress syndrome. I'll be calling it PDS as an abbreviation. And if the patients have bothersome epigastric pain or bothersome epigastric burning, at least even if once a week, then these patients are labeled as epigastric pain syndrome. And the symptoms should be active during the last 3 months, and the onset of symptoms should be at least 6 months before the diagnosis. So these criteria, if the patient fulfills these criteria, and there is no structural evidence in the upper GI endoscopy to explain the symptoms, as we discussed earlier on, then we label the patient as epigastric pain syndrome or postprandial distress syndrome. And to note this, the bothersome term was added in the Rome 4 to indicate that these symptoms should be bothersome enough or good enough to disturb the patient's daily life. So patient should be, it's not that mild pain or mild burning should be labeled as this syndrome and it doesn't need treatment. So these symptoms should be bothersome enough and should be in continuity, and there should be no organic disorder. And then we label these as functional dyspepsia. So these are two subclasses, PDS and EPS. So differential diagnosis, we already discussed in brief, but if we see the data, chronic peptic ulcer disease can be there in 15-25% of such patients which seemingly have functional dyspepsia. Associated GERD is present in 5 to 15%, and some series maybe more than 30% also have GERD. Malignancy, just 1 to 2% patients do have in some series. Gallstones can cause dyspeptic symptoms, but normally the pain of gallstones is severe enough to have a different presentation. Chronic pancreatitis or pancreatic cancer to begin with will have dyspeptic symptom, but these are not true differential diagnosis of dyspepsia because these patients have a different pain, has a higher severity of pain. Yes, celiac disease in areas which is common as in northern India, they can present with just dyspepsia alone. They might not have diarrhea, but yes, they will have anemia, and which can be give us a clue to underlying organic disorder. Lactose intolerance patients can have bloating and more of bloating and plus dyspeptic symptoms. So again, where the areas which is common, we have to rule out this disorder. Then there's a term called as non-celiac gluten sensitivity, in which the markers of celiac are negative. Anti-TTs is negative, endoscopy and D2 biopsy may be normal, but still the patient might be having intolerance to wheat. We can say this is called non-celiac wheat sensitivity. And that is also now being reported in our country. We recently have published this data in a journal. So, and as we discussed, 60 to 70% patients will not have functional dyspepsia, will not have any organic pathology, and we label them as functional. So this is a diagram I was talking that time that funding relaxation plays a major role in meal-related response to symptoms. If you see in the upper diagram, the fundus accommodation or receptive relaxation, as we call, gives space to the food which we eat. But when this is impaired, the food is redistributed to the antrum, and the patient will have dyspeptic symptoms. So this pathophysiology was shown first by Jan Tak et al. In 1998, and it is very, very important because of therapeutic implications. So because of this problem, so we for treatment of such patients, so any acid suppressive therapy will not help. So therapy which relaxes the fundus will help. So my colleague Dr. Srihari will talk on such therapies which help to relax the fundus. So how do we approach such a patient? So this is the diagram taken from the Rome 4 criteria, which were published 2016, way back, but these are very good flow diagrams. So it sums up all which I have discussed till now. So symptoms of gastroduodenal involvement, patient having such symptoms like satiety, pain, burning, nausea, vomiting. He take history and proper examination. If the patient has alarm features like anemia, bleeding, weight loss, or some mass or some jaundice. So in these patients, you get a quick evaluation with upper GI endoscopy and biopsies because these patients have very, very high likelihood of having organic disease. If the patients do not have these symptoms, we label these patients as uninvestigated dyspepsia. And here we can start empirical therapy. Which, and then if the symptom resolve, we give continue treatment. Then there's a concept of H. pylori testing and treating, which I talked. If it eradicate H. pylori, if symptom resolve, is good. If don't know, then it is functional dyspepsia again. So this is how we follow this algorithm. Patients who have normal endoscopy, now the question is a patient is on PPIs and so but not improving, endoscopy is normal, how to proceed? So this is a second aspect. Now we should study the gastric functional tests are there. So these patients might be having gastroparesis, problem in gastric accommodation, problem in gastric myoelectrical activity. So I will not go into details, but just because it's not a part of today's seminar, today's talk, but I mean, we should, this test, we have scintigraphy, which tells about gastric emptying. We have breath test, which also tells about gastric emptying, spirulina breath test, C13 breath test. PCM absorption test, not widely used. Wireless motility capsule, not available in our country. Ultrasound and plus electrogastrography also can help in knowing the gastric emptying. For gastric accommodation, the tests are slightly again not available everywhere. SPECT is the ideal test for that. Barostat again is not available. MR imaging and ultrasound can tell us gastric accommodation. So in patients who have persistent meal-related symptom, we can go for these tests. Gastric sensory function, we have Barostat and Tensostat and water nutrient satiety test, in which give a specific amount of water and we see how much water the patient can take. While now the emerging test is electrogastrography, which tells about the myoelectrical activity, like it helps to differentiate. Like the upper test, the scintigraphy, another test will tell us, okay, the stomach is not getting emptied. But there may be, broadly speaking, two reasons for stomach not getting emptied. One is the stomach body is not moving at all, or there's problem in the pylorus, functional obstruction in the pylorus. The pylorus otherwise is normal in endoscopy, but it is not relaxing. So that is no get we get to know by electrogastrography. So when we get this test done, we can differentiate between a weak stomach or a functional gastric obstruction, that is called APDO, because the treatment modalities are different. So this is an important modality in patients who have PDS type of symptom, gastroparesis type of symptoms. Symptom assessment questionnaires, yes, we have Napier Dyspepsia Index. There's another short form of Napier Dyspepsia Index, and in our center, we 5 years back we used this and we translated it into Hindi version and validated in our population. Then we did a couple of studies and we found it very useful to quantify the symptoms and to reassess the symptoms after some therapy or some intervention. And it tells about the severity of symptom also and the quality of life also, all in one questionnaire. I will just now briefly talk one to two, I mean, maybe one case study just to show how we approach a patient. So this is a 35-year-old male driver by profession who came to us with postparental fullness, epigastric pain, early satiety from past 4 months, and also patient had some heartburn, belching, and nausea. Work life, yes, we need to ask in all patients because of his work life and night duties. He had irregular food patterns, irregular sleep patterns, and showed depressive symptoms with social withdrawal symptom also. And he did not have any history of NSAIDs, which is very, very important in some dyspeptic, all dyspeptic patients. We should ask about drug history. So NSAIDs or other disorder medicines were not there. And he had taken almost all PPIs like lansoprazole, esomeprazole, and etc. for the past 8 weeks, but they could not improve his symptoms. His BMI was fairly good, even maybe actually on the higher side. The vitals were stable. There was just mild tenderness in the upper abdomen. So basically, he did not have any alarm sign, but because he was so much disturbed, 4 months of symptoms not improving, we went for upper GI endoscopy. It showed mild non-erosive esophagitis, and so we took. There were biopsies from esophagus because he had retrosense symptoms also, and we took biopsies for H. pylori also. So there was no eosinophilic esophagitis, no organic disorders, or no hiatus, and the enteral biopsies were also normal. And his sometimes he said he had dysphagia also. So we did his this manometry because of predominant dysphagia, occasional happening. That showed ineffective esophageal motility, which is a minor disorder of motility. So, I mean, this was a so what based on this, what would we consider the choices? So the patient actually the dyspeptic symptoms were the major symptom, and the motility disorder symptom were lower. So we can easily label this patient as a functional dyspepsia based on the Rumford criteria, as organic diseases were ruled out. The symptoms we assessed on the Likert scale were moderate to severe, and this non-erosive esophagitis and the minor changes on the this endoscopy which were detected, yes, we do label as ineffective motility, but that does not cause dyspeptic symptoms. So dyspeptic symptoms were easily we can label as functional dyspepsia. So I think I can stop here, and we can move to the next important part of treatment.
Thank you, Dr. Umesh, for a very clear algorithm. Although the topic is such, there will loads and loads of gray areas. So we will discuss after the second talk. So I invite Dr. Srihari for the next part of the talk, that is management of functional dyspepsia. Dr. Srihari is associated with Sir Gangaram Hospital, and he has interest in functional FGID. And I invite him to start his talk. Dr. Srihari, please.
Thank you, Professor Sinha, and thank you, Dr. Goel, for that excellent talk. Are my slides visible, sir?
Yes.
Yes. So the topic allotted to me is treatment of functional dyspepsia. What I would like to highlight more is, in fact, management strategies for refractory functional dyspepsia. I think the conventional over-the-counter functional dyspepsia, each one of us manages very well. and that's not much of a challenge managing a routine case of functional dyspepsia. But we all have patients where the dyspeptic symptoms just don't seem to go away, and that is when you are worried. Are we dealing with this patient in the right manner? Do we continue treatment? Do we refer this patient to a psychiatrist? What do we do? So my impetus would be more on refractory functional dyspepsia, and I will also touch a bit upon the conventional management strategies. So as Dr. Umesh Goyal rightly said, so whenever we talk of functional dyspepsia, basically dyspepsia is a symptom constellation which is related to those arising from your upper gastrointestinal tract. It can be the stomach, it can be the duodenum. So it can be bothersome epigastric pain or burning. It can be bothersome postprandial fullness or early satiety. And these symptoms have to be there since at least more than 6 months, with active symptoms since the last 3 months, in the past 3 months. And it should be at least 1 to 3 times per week, obviously without any evidence of any structural disease to call it as functional dyspepsia, according to Rome 4, right? So when do you label a patient as refractory functional dyspepsia? When does a patient with functional dyspepsia become a patient with refractory dyspepsia, right? So any patient with functional dyspepsia, obviously you ruled out organic causes in these patients and you start treating this patient. So as the first step, usually what is recommended is a mix of diet and exercise. And it is also wise to evaluate for H. pylori in all these patients, because it is now seen that H. pylori related dyspepsia, it's actually now a distinct entity. It is considered a distinct entity. Previously, it was thought to be an element of functional dyspepsia itself, but now H. pylori associated dyspepsia is a distinct entity. It has to be tested and treated if it is there, and then you move ahead, right? So if you talk about diet, there have been various types of diet that have been tried and attempted, including low FODMAP diet, gluten-free diet, etc. But most of the studies and meta-analysis now tell us that the only diet which really helps in a lot of people is a diet which is low in fat content and asking the patient to take small volume meals. Yeah, so that is what has been recommended by most of the guidelines now. If we talk of H. pylori treatment, H. pylori associated dyspepsia, in a country like ours where H. pylori is so common, where around 60 to 70% of the population is expected to be infected by H. pylori, there are certain problems. Do we all assess for eradication? How do we assess for eradication? When do we assess for eradication? Actually, once you have eradicated H. pylori, the symptoms just don't vanish immediately. It takes around 6 months for the H. pylori eradicated symptoms to disappear. So how do you know that the patient has been treated for H. pylori and these symptoms were really associated with that? And we all actually really still don't know how much is the drug resistance in India. We all use these H. pylori regimens left, right, and center. And we already know that there's a lot of clarithromycin resistance quoted in the literature, but it might be much more than what it is actually there in the literature in our country. So after we have done this, then based on the type of morphology that Dr. Umesh commented upon, you use either an acid suppression or a prokinetic. If it is more of an epigastric pain syndrome, the acid suppressive therapies are more useful. If it's a postprandial distress syndrome, the prokinetics are usually the drugs of choice which help you in managing a patient with a postprandial distress syndrome kind of a functional dyspepsia, right? So acid suppression, you have the options of proton pump inhibitors. Now you also have the PCABs, you have the H2 receptor antagonists. Prokinetics in India, we do have a huge gamut of prokinetics that are available. However, globally, these are very much restricted. Not all drugs are available everywhere because there have been some events, adverse effect events that have been noted with most of these prokinetics. So that is why they are not available as a general prescription in most of the countries around the world, especially in the West. But in India, luckily, we have most of these prokinetics available to us. So just briefly discussing about prokinetics, why do you need prokinetics? Because we know that proton pump inhibitors are effective, especially in epigastric pain syndrome kind of dyspepsia. But when you talk of a postprandial distress syndrome, you need to add a prokinetic. There were different prokinetics which were studied, including mosapride, etopride, etc. But none of them were shown to be very useful. Levosulpride was tried, but there was a lot of side effects with levosulpride. Domperidone again had a lot of side effects. Metoclopramide, prucalopride has been tried a bit, but it was not found to be very useful. That is when most of us switched to acoshiamide. We have this excellent prokinetic agent available in the market. So this was first developed and approved in Japan in 2013. And in a way, it is the first drug which has been approved for functional dyspepsia for postprandial fullness syndrome. Long-term phase 3 trials have been completed, and they have shown that it's a safe drug, which is an effective drug. And the mode of action of acoshiamide is that it acts by enhancing the acetylcholine release at the neuroreceptor levels, and it also prevents the breakdown of acetylcholine by inhibiting the acetylcholinesterase enzyme. It has a very good risk benefit ratio, and this is especially useful as when you compare it with other available prokinetics. It does not cause QT prolongation or other significant cardiovascular ill effects, and it has virtually no specifically indicated safety concerns. So I already discussed how it acts. It acts by enhancing the acetylcholine release and reduces the acetylcholinesterase, reduces the breakdown of the acetylcholine by preventing activity of the acetylcholinesterase enzyme. So by providing more and more acetylcholine to act on the stomach, it helps in the phenomenon of gastric accommodation, and it also helps in improving the gastric emptying, and that is how it helps us in treating the dyspeptic symptoms, especially the postprandial distress syndrome. So the approved indication and dosages is that it is approved for the treatment of meal-related functional dyspepsia such as postprandial fullness, epigastric bloating, and early satiety. And the adult dosage of acoshiamide is 100 milligrams orally 3 times a day, each of them before meals. Yes. So now there have been a lot of studies, including acoshiamide being given for more than a year, and they have shown excellent results. Long-term safety and efficacy profiles are excellent, and it has now been accepted as a very good drug, not only in practice but also proven in most of the studies in the literature, right? So you have started these patients, a patient with functional dyspepsia, on treatment, and you have been giving this, and for 6 months the patient is on treatment, but still the patient has symptoms, he is not improving. That is when these patients are labeled as refractory dyspepsia, and it is seen that around 20 to 40% of people suffering from functional dyspepsia will be eventually needing some other therapy, and these are patients with refractory dyspepsia. So how do you go on to evaluate, investigate, and treat such patients? So whenever we talk of refractory functional dyspepsia, I think we need to answer these 4 important questions. Is it just functional dyspepsia? Are we missing something? Is it really functional dyspepsia? When I talk of is it just functional dyspepsia, I'm talking of is there any other associated overlap of any other functional syndrome along with the functional dyspepsia? Are we using the right pharmacotherapy? Do we have any other pharmacotherapeutic options apart from the conventional medicines? And what is the role of behavioral therapy? So is it just functional dyspepsia? So a patient who presents with the typical symptoms that we know, epigastric pain, the postprandial distress syndrome, that is okay. So it is important to note that bloating, belching, nausea may be presented in functional, may be present in functional dyspepsia. But if a patient complains of significant nausea or there is persistent vomiting, it is very likely that we are dealing with a patient with gastroparesis and not just functional dyspepsia. If the patient has significant heartburn along with the symptoms, it's very likely that we are treating with prominently a patient with GRD along with functional dyspepsia. If the patient complains that his symptoms go on reducing with passage of gas, it's probably an IBS overlap. And if the patient has a significant dietary restriction and has led to significant weight loss, we are probably dealing with a more severe kind of disease, which is called as ARFID, which is an avoided restrictive food intake disorder. And that is likely, that is where you have to see. Is it really functional dyspepsia? Sometimes you need to revisit your diagnosis. Have we thoroughly investigated these patients? To tell you some very notable examples, patients with GB microliths or a stone just stuck there at the GB neck. This might not be always picked up on an ultrasound. We have had many patients where where you do an endoscopic ultrasound and you see that the gallbladder is full of microliths. You have an annular pancreas, which is not picked up by an experienced radiologist. Subtle mucosal findings on the endoscopy, like H. pylori associated gastritis, which was not picked up by the kits which were not standardized. Certain very subtle findings on the endoscopy. We have had cases of lead poisoning, people who have been taking complementary and alternative medicines who were undiagnosed and being treated as functional dyspepsia for long. We have had patients with porphyria. In fact, I still remember 2 patients with porphyria who were being treated as functional dyspepsia for a long period of time and eventually diagnosed as porphyria. So when the patient has persisting symptoms, I think it is once time that you again go back and revisit whether you have done a thorough assessment of these patients or not. Pharmacotherapy, we have discussed some basics. So whenever we talk of pharmacotherapy for functional dyspepsia, there are these most important targets that you're dealing with. One obviously is the neurological target, that is the visceral hypersensitivity, altered CNS processing, psychological disturbances that we all know. Then comes the target of impaired fundic accommodation, delayed gastric emptying, and as Dr. Umesh said, duodenum is now considered a very important target for patients with functional dyspepsia because it might be actually the reason for functional dyspepsia in a lot of patients. Duodenal inflammation is known to cause this. So when we talk of visceral sensitivity or the CNS processing or psychological disturbances, you have the psychotropic drugs, tricyclic antidepressants or the selective serotonin receptor inhibitors. So when we talk of tricyclics versus SSRIs, it has been seen that the tricyclics work very well, in fact, much better than SSRI. So when you talk of treatment of functional dyspepsia, it is always preferable to use a tricyclic antidepressant rather than a SSRI because the rates of relief with SSRI are as much as a placebo, not significantly different. It is obviously significantly different when you use a tricyclic. And with a tricyclic, it actually helps more with an epigastric pain syndrome kind of functional dyspepsia rather than a dysmotility or a postprandial distress kind of a functional dyspepsia. So whenever you have a dyspeptic patient with epigastric pain syndrome, tricyclic antidepressant is the drug to go to, not the SSRI. It usually doesn't help. Imipramine has shown a benefit in both the epigastric pain and early satiety, but it is usually more useful in epigastric pain syndrome kind of a functional dyspepsia. There is a tetracycline also available in the market by the name of mirtazapine, and it has also shown benefit in patients with functional dyspepsia. But the problem with mirtazapine was there are not very well-powered studies to prove its benefit. Smaller studies with smaller endpoints that have been used. Pregabalin is one of the agents which was used in functional dyspepsia and did show some benefit. So these are the psychotropic agents that are available. Then you have agents which work on multiple targets, including the neurological targets, including the fundic accommodation and the gastric emptying. And this is where levosulpiride is a very useful agent. So you must have all noticed that when you use levosulpiride, a lot of patients have fantastic relief when levosulpiride has been used. Studies have shown that. And tandospirone is one 5-HT1 agonist, which also acts on all these targets and might be useful. The problem with levosulpiride, however, is that it has a lot of extrapyramidal side effects, and it is recommended that it should not be used, especially in the elderly people, because sometimes these side effects are irreversible. So when all these different agents, the neuromodulators have been were evaluated against each other, it was shown that the antipsychotics and the tricyclic antidepressants are the agents which are really, really useful. The 5-HT1A, the SSRIs and SNRIs did not show much benefit when seen in the meta-analysis. So the antipsychotic agents and the tricyclic antidepressants are the one which have shown benefit. But if you look at it much, much more carefully, it is only the tricyclic antidepressants which have a very good, moderate quality of evidence and strong recommendation. The antipsychotics still don't have a strong recommendation. They still have weak recommendation or a low quality of evidence. So among all available agents, I think as of now, the only tricyclic antidepressants are the one which really help in refractory dyspepsia. So the question is, how do we improve acceptability? A lot of people will not be able to take this very often. So it is important that you give these agents before bedtime. There is a lot of sedating effect to these agents, but these effects are short lasting. They tend to ameliorate over a period of 1 to 2 weeks. So you can ask the patient, tell him that these will not be forever. This will be stay for a week or two, and then it will go away. You should start the treatment at the treatment obviously for the GI doses are much lower than the antipsychotic doses. So again, that is what reassures the patient, and you can titrate these doses gradually as the patient's efficacy is seen. If beneficial, these drugs can be continued for a period of 6 to 12 months or even longer if required. Behavioral therapy, you have different behavioral therapies like psychodynamic psychotherapy or cognitive behavioral therapy, stress management, mindfulness, or hypnotherapy. I will not go into all most of these details, but again, these behavioral therapies do not have significant quality of evidence, which is still quite low, and the recommendation again is still not very significant for these. The newer targets now are working on the duodenum. It is thought that the duodenal disc biopsies or the duodenal inflammation, where there's an increase in the eosinophils and the mast cells, are known to cause a lot of dyspepsia in patients. So now you have different agents which have been tried and tested, which are actually acting on these targets. Like you have studies on rifaximin. You have L-menthol, which acts as a soothing agent, which is working on the duodenum. And you have these mast cell stabilizers like Montelukast, which have been tried to reduce the eosinophil count and stabilize the mast cells in the duodenum for patients with functional dyspepsia. Also, adding a H2 receptor antagonist like ranitidine might be a good option in patients with refractory dyspepsia, because then it again acts on the histamine receptor, which is present, which is acting through the mast cell. So adding on an H2 receptor antagonist might be a good idea in patients with functional dyspepsia. So refractory functional dyspepsia is seen in 20 to 40% of patients with functional dyspepsia. Competing etiologies have to be considered before you label this patient having only functional dyspepsia. Tricyclics are shown to have best results among neuromodulators, and the duodenum seems to play a major role in pathophysiology. Future treatment may possibly be directed towards it. Thank you so much.
Thank you for a very elaborate discussion and a very practical approach.